Hey everyone, welcome back to Symmetrically Fit. My name is Dustin Gotro with Symmetry Personal Training. I've got with me today Katy Girlinghouse with the Fit Pelvis and Dylan Stone, the DMI guy. So today we're going to be talking about hypermobility. Now, this topic, my knowledge level is slightly limited just because I don't see it a ton with clients that come in. So Dylan and Katie will kind of be covering most of everything today. I'll refer to them since they actually see it in their realm a lot more than I do. Um, Hypermobility can definitely affect your ability. I think a lot of people don't see it as much of a problem. It can really affect your ability to move properly just as much as any other condition, muscle imbalance, injuries, chronic pain. So I think it's going to be a really interesting topic to cover. So if you suspect that you may have some hypermobility in some joints in your body, tune in and learn how to correct it today. So we're going to jump directly into it today. So Katie, let's start off with what hypermobility is. So just kind of explain what we're looking at here.
Yeah, so we all have a range of how much our joints move, and some people are a little bit stiffer, and some people are a little bit more mobile. And people who are on that mobile end, but still in the range of normal, are going to be hypermobile. So their joints move a little bit extra, and their ligaments that support the joints just aren't as tight and aren't as stabilizing as somebody who's on that stiffer end of the spectrum. So that's going to be basic hypermobility. But with that, we're not looking at anything like an Ehlers-Danlos or a true hypermobility syndrome. Those are the next level. We're saying those are outside of the range of normal, of typical mobility. And those people are going to have whole body hypermobility throughout all of their joints. And they're going to have other issues, but it might also affect other connective tissues throughout the body, not just the joints.
Okay. Good. And we'll get into that a lot more here in a little bit as far as what different types of hypermobility we see. We'll have Katie kind of differentiate between all of those a little more detailed. Dylan, what are some signs that you typically see with hypermobility?
Yeah. So, well, first, I wanted to really highlight what Katie said, and I like how she kind of distinguished between hypermobility of a typically developing person versus a congenital hypermobility, right? So we can, I mean, Dustin, you and I have seen through our personal training, there are people who are they have no diagnosis, but their elbow just bends a little bit too far or straightens a little bit too far. It's just one joint, right? That's the main thing, one or two joints. And then something like Ehlers-Danlos EDS, or our classic example in pediatrics is Down syndrome. All the joints are affected because it's a systemic, or it affects the whole system. So typical things we see, and I'm gonna bring you guys through a little bit of a test that we do in physical therapy. So it's called the Baton scale for hypermobility. It's testing exactly that. It's testing if there's a systemic hypermobility. And then it kind of gives me, as a physical therapist, gives me insight on how to approach a child if they are systemically hypermobile. So everything we do is going to be scored 1 point. And the first 4 points are sitting. So you can just do this sitting. So first one is going to be straighten both your elbows, if you can even see that. So both your elbows, look at them and see if they're just a little bit over like 10 degrees the other way, hyperextended, right? So if they are, that's 1 point each for each of the elbows. Okay. The next one is, I'm not going to do it because I don't have a table in view, but put your hand flat on a table and then bend your pinky up. Push it up as far as it can go. Yeah, there you go. Katie's doing it. Yeah, you can. Yeah, you need a third hand, Katie. Push it up as far as you can go. If it goes past 90 degrees, which Katie's at about 45, then that's another point for each hand, right? The next one is taking your thumb and trying to push it towards your forearm, right? As far as you can go. Be another point for that. So right now we're at, so 1 point each for the pinkies, that's 2. 1 point each for the thumbs, that's 4. 1 point each for the elbows, that's 6. Next one is if you stand up, then if you stand up and you straighten your knees all the way, and your knees straighten past 10 degrees, so hyperextend, that's a point for each of those. That'd be 8 points. And then the last one is if you can go down, touch your toes, and put your palms on the ground. That would be another point. So there's 9 total points, right? So you add up all those, and if you score over a 4, then you're considered systemically hypermobile. So, for example, I score a 3, right? I score a 3 on that scale because my pinkies go back really far. But here's the thing, you guys probably know this about me. I was a cheerleader in college, and what do you do when you're holding someone in the air? Your fingers get pushed back a lot. They just get pushed and pushed and pushed. So I have what's called a functional hypermobility. It's because of something I did in my life that makes me hypermobile. So it's not that my ligaments are loose or anything like that. It's just that what I did repetitively for so much made me score on that list. So, um, for things like, if I was seeing a gymnast who's hypermobile, of course she needs that to do her gymnastics. So I'm not going to train her to not be hypermobile. I'm going to teach her how to stabilize while she's hypermobile. And I know I'm getting off topic on my question here, but I'll just finish up with that functional hypermobility is sometimes good as long as you can control yourself in that range of motion.
All right. So we're back to the original question now. What
Yeah, I know.
are what are some typical signs, more in terms of, for listeners? Let's say
Yeah.
somebody's not sure if they're hypermobile or not, or they know that their knees hyperextend, but they're not sure if it's a problem or not. What are
Mhm.
some other signs like that that they may see and think, "Hey, I need to go get this checked out"?
Yeah. So, have you noticed how much I love this topic? Because I'll go on for 7 minutes about it.
Yeah.
Um, okay, so I'm gonna stick to the question this time. So, what if you see that your knee is hypermobile or that you hyperextend your knee? What is kind of your step to, like, I should go get this checked by a doctor or go to a physical therapist? If that's bothering you, right? If you hyperextend your knee and it's painful. And I'd say the most glaringly obvious thing is that if you hyperextend your knee and you can't control it, right? You take a step, boom, you hyperextend and it hurts and you can't control yourself in that range of motion. That would be, I say, see Katy or myself, see another physical therapist, because what we need to do is we need to build up the muscles around that joint so that you can control that extra range of motion that your tissues are allowing for.
Awesome.
I
Go
want
ahead,
to add
Katie.
to that. So a lot of times what you'll feel like is you need to like pop that joint all the time.
Mm-hmm.
And you'll pop it and then it'll feel good for a short time. But it doesn't last and you feel like you need to pop and pop and pop and pop. And so you get that. And then the other thing is stretching might feel good to like immediate, like while you're stretching, but it often feels worse later because you're stretching the end of that joint. You have no ligament stability in the joint. So you're just stretching the joint even more into hypermobility. So stretching does not feel good for you.
That's a good point. That kind of goes back to don't stretch your hamstrings concept. Don't stretch things that are already too stretched out. So we'll get into more detail on this later, but just briefly, Dylan, what's the risk here, right? So I gotta imagine people are thinking, all right, well, I'm too flexible, I'm too mobile. Why is that a problem? What's the risk to the body when we have this issue?
Sure. So, the risk we see a lot, and I'll take the knee as an example. The knee is always a good example of this. So we have a capsule around the knee that surrounds the knee and it keeps fluid inside the knee. So below the thigh, above the shin, where that fluid keeps things mobile, right? It makes things move. And so if we go into that hyperextension and we push too far, we start stretching the back of that capsule. Um, and the more and more we stretch it, that tissue is not as responsive as muscle. And so if it keeps stretching, we may cause issues to that capsule, and then we could possibly lose the fluid inside of there, and then we get issues with that knee not having enough fluid to do its job to bend. Or Katie, can you think of any others that like kind of the hypermobility and where that kind of comes into play?
Yeah, so what I see is people are just predisposed to get injured more often. So like for me, like my elbows are a little bit hypermobile, and for me, I have to be mindful when I'm lifting that I'm not hyperextending that elbow and putting the force on the capsule, that my muscles are actually doing the work and not just the joint. So they're just more likely to get hurt.
Mm-hmm.
Yeah, perfect. All right, so we're going to kind of get into the deeper details now. So, Katie, let's start with you. I want to differentiate hypermobility, EDS, and unstable joints because I think that's where people need to decide, is this a problem I need to address and who do I need to go to address it?
Yeah, so like I said, hypermobility could be one joint, it could be a handful of joints, but it's less likely to be every joint in the body, though it could be many of them. With EDS, there's a genetic component. So it's something that you've had your whole life. It's something that's going to affect every joint in the body. And it may also affect other connective tissues. So it could affect skin, it could affect the vascular system, your blood. So it's going to affect a lot of other things, and you may have a lot of other symptoms on top of just the joint symptoms. Um, with the hypermobility, I would say it doesn't always need to be treated, but usually when it needs to be treated is when you start having pain. So, like with the knee, if you're hyperextending constantly every time you are running and you injure that knee, then you go into PT, you work with them. They're going to address that underlying hypermobility to help give you more stability so that you are less likely to get re-injured. Um, versus someone who may be a little bit hypermobile, but they're not pushing their joints to that in range all the time. They don't necessarily always have to get that um, treated. And then if we look on like past the hypermobility, if we think about truly unstable joint, so this is a joint that either is missing some ligaments, they're torn. So if you think about a sprained ankle, if you tear the ligaments in your ankle, you're not going to have, sorry, my dogs are wrestling behind me. Um, the you're not going to have stability in the ankle. So you might continually roll it. You might keep re-injuring it because you just don't have the ligamentous support. And that may be something that muscle wise you can compensate for, or it may be something that really needs surgery to give you back that stability.
Okay. With I'm not really familiar with EDS, so what, as far as treatment for that, I would assume that's something that needs to be treated, correct?
Yeah, Dylan, do you deal with this more? You work with
Yeah.
people with EDS? Yeah, I'll let you answer that.
Okay. Yeah. So EDS
Either
stands
one.
for Ehlers-Danlos syndrome. It's just like Katie was saying. It's a congenital. There's a genetic component, so you're born with it, right? Um, and it. So, Katie, I'm not up to date completely on the medical interventions, but physical therapy is proven to help with it. I don't know if there's an injection or a medicine that's beyond what physical therapists do. But do you know, Katie?
Yeah, I don't know what it is, but I know that and it depends on how severe, because there's different stages of Ehlers-Danlos. So, like I said, some people could have blood affected, and some people could only have joints and or skin. So there are other treatments, but I think it depends on where your symptoms lie.
Mm-hmm. And I think the
Interesting.
thing to boil it down to is that no matter what the medical intervention is, physical therapy is proven to help with EDS. The stability, the strength that you get from it, and to throw you a bone, Dustin, you guys probably all see the letters behind Dustin's name, National Academy of Sports Medicine. So I was NASM certified with Dustin, And the running joke is that when you walk into a gym, you can see the NASM certified guy because he's the one who has his client on a ball with a weight. Like NASM is very much about stability. So even if you don't come into the realm of medical, into physical therapy, you can go see Dustin. Dustin does a lot of stability work because that's one of the foundational principles in NASM is stability.
Yep. Lots of stability and symmetry, hence the name of my personal training. Okay, so Katie, you kind of touched on this already, but I want to get a little more detailed in the typical treatment method for hypermobility. So, more of not necessarily EDS, unstable joint, but actual hypermobility. Um, Run us through the treatment for that.
Yeah, so it's basically joint stabilization. So how well can you get the muscles as the closest muscles to the joint to fire and coordinate to give that joint stability so that you're not always going to that end range of motion and kind of pulling on those ligaments and stretching them over and over. So it is going to be sometimes it's really basic looking stuff and then you're going to build up and add more complicated things. But it all, I mean, like Dylan said, it all comes down to stability for all of people, honestly, for all three. If you have hypermobility, if you have a congenital hypermobility, or if you have a truly clinically unstable joint, where all of them we're going to look at what can we do to stabilize the joint, and depending on the joint, those exercises are going to look totally different, but they're the ones that we typically start with that are more basic.
Dylan, let's pass that one to you. Treatment method. Do you find anything different in the treatment method when you're dealing with pediatrics?
Yeah, so it's night and day for pediatrics, but just because it's I wish there were some patients where I could just give them exercises and be like, here you go. But the fact of the matter is that they're kids, and so you got to make things fun and engaging, and so where it comes down to with stability with children is playing those types of games that elicit stability. So the floor is lava is a great one, right? You just put a bunch of stuff out on the floor and say floor is lava, and then they have to jump between things and stabilize. But if I had a more involved patient that needed a little bit more stability than just jumping around, what that would look like is me with my hands providing stability to whatever the joint is. It's typically an ankle or a knee in pediatrics. And then holding them in that position until their brain kind of gets, oh, I need to be in this position to be stable. And then as soon as their brain gets that, I slowly release my support. And then their muscles just, oh, I need to take over because Dylan's releasing, right? So it's the core concept is the same as in adults, where it's stabilization, stabilization, stabilization. But I just have an added component of games because these are children.
Yeah.
Yeah.
I'm interested. Do you find there a difference in the time that it takes either a kid to learn these things, or I guess more what I'm asking, does a child's nervous system pick up on that stability and fire the muscles at a different speed than what you would see with an adult?
Yeah, so that's a great question because we have a principle called plasticity in the brain, where it's basically how fast our brain can adapt to new things. And when we're new to this world, our brains are very plastic. We can pick up on new things very quickly, and we can adapt. So one of the main things I offer at my company is I offer intensives, which are 2-a-days for either 1 or 2 weeks, because kids are so plastic, they pick up on things so quickly that you can push them through therapy for 2 hours a day and they'll pick up on everything you're putting down. So with adults, Katie, you can kind of vouch for this. You get an hour in with adults and they're like, I'm done. We're done here. I got to go home. But with kids, you can push them a little further because their brains are just such sponges, right? So I'd say that in pediatrics, kids pick up on things a lot quicker. But then, of course, you have the added factor on if they're completely there cognitively, because there may be other things going on. But that's a topic for another podcast.
Yeah. Yeah. I
So
mean,
it would
I,
definitely make sense in general to deal with hypermobility as young as possible.
Yeah, yeah, definitely. I mean, there's obviously a limit because we need them to be doing certain things. I can't see a 1 week old and, and be like, you're hypermobile. um, but they have to be doing some stuff so that I can actually train them. Like I need some clay to mold. But um, yeah, once hypermobility is identified, addressing it as quickly as possible is best.
Okay. Katie, I want to go back to you for one more question that's on our list. But then I have a few random questions for both of y'all after that I want to get into. We'll have
Of
a little
course.
fun with some rapid fire. Um, so you mentioned earlier, Katie, that a lot of people with hypermobility feel like they need to stretch all the time. Um, Explain to us exactly why that is that they feel that way, and should they, just to reiterate, I know we said it already, but just to reiterate, should they be stretching that area?
yeah. So, no, they shouldn't be restretching. I mean, they shouldn't be stretching that area. They feel like they need to stretch because it just always feels tight. And that comes from the muscle trying to do the work of the ligament and the muscle. So they're overworking a muscle. And if they're stretching it, they're overworking a muscle that's already lengthened and at a disadvantage to activate effectively. And so it just always, their muscle will feel tight because it's trying to work hard. If you let that relax, don't stop stretching it, it will tighten down a little bit and then strengthen it. It will stop feeling tight.
Okay. All right. So some random questions, because I'm learning just like the rest of everybody listening to this. So first, with hypermobility, how much of it is nervous system, and how much is it the structure of the body, or is it a little bit of both? Who wants to take that one?
Mm. Katie and I are going to have different answers for this.
We are.
Let, let's
Yeah.
let's get to both of them.
All right. So my population, children, is very much nervous system. Just because they're new, right? The nervous system's new. It's only been handling gravity for a couple years. Adults, they've been handling gravity for 30, 40, 50 years. But these kids have only known gravity for 5 years. And so um, having to stabilize against that kind of surface and it's all about neural development with me. But go ahead, Katie.
Yeah. So with my patients, I would say it's the opposite. It's more that their ligamentous structure is what's causing the hypermobility, but they have been hypermobile for a long time. Often they didn't develop that last week unless they stepped off a curb and sprained their ankle. But most of the people I say they don't have an injury per se that started this. It just developed over time. And so their nervous system is used to using that whole motion. So I do have to retrain the nervous system to use a new range of motion and to act differently to stabilize that joint.
I got you. So there is still some nervous system dysfunction, but I think what you're getting at is it's caused by the hypermobility itself
Yes.
being there for so long. Okay, awesome.
Yeah. Yeah.
All right, so what I run into in my realm, so I think most people know I was in CrossFit, I owned CrossFit gyms for almost 9 years. So I've seen a lot of Olympic lifters, a lot of different higher level athletes, and now I'm back in corrective. So what I see in my realm is the squat. That's always where I see it. So if you're dealing with, say, a gymnast or a dancer, that hypermobility that they have from overstretching for so long, and I believe, Dylan, you term that as a functional um,
Mm-hmm.
hypermobility.
Yep.
At what point do people need to say, okay, this, we need to correct it? Like, how much of that is okay if their body's still functioning properly?
Yeah.
Who wants that?
Um, I'll go just because I termed functional hypermobility. So that was a term
Yeah.
I used a lot with. So I worked in outpatient pediatrics where instead of like the neurological diagnoses, you see a lot of athletes there. So I did treat a lot of gymnasts, a lot of cheerleaders, dancers, who their sport requires hypermobility. If you've ever seen a step team do or a drill team do high kicks, like that's hypermobile, but that's required. So where I sat with that is that if it requires hypermobility, let's learn how to control that extra range of motion, right? So it's not about getting them back to this ideal textbook range of motion. It's about controlling what you have to do for your sport. I had a really good, I still do, I had a really good mentor, Chris Maya, if you want to look him up. His big motto, he said this to all of our patients. He said, it's not, there's no perfect posture. There's just postures you're not used to yet. So where issues come in is if you're not used to a certain position, that's when you start getting injured. So all that to say, oh boy, let's get back to the original question where functional functional hypermobility is okay as long as you are in the sport that demands it. If it starts hurting you, then let's do something about it.
All right. Follow up question from that question for Katie. After I guess season in their life. So let's say we have a dancer, a gymnast that's hypermobile, hips are kind of in that anterior tilt that we typically see with those. Once they're done with that, is it okay to leave everything, assuming they have the stability in the joint? Is it okay to leave it there, or would it make more sense to correct that hypermobility since they don't have to be able to do that anymore?
So, I would say that we can't correct it as like I can't tighten down the ligaments. The only thing that can do that is surgery. So, I would say like say I have an ex dancer, right? And I do see a lot of ex like ballet dancers and gymnasts and cheerleaders postpartum because they have all this hypermobility that they needed for their activity. Then they got pregnant, had a baby, and now they're weak. So they have when they lose the strength is when it becomes a problem. So I don't really care. Like they may be 80 and they've never had pain and they still can put their foot behind their head. And if they can do it and they feel good, more power to them. I don't care. Um, but you got to maintain the strength. So when they lose the strength, um, we really work on building back up the strength. They're going to lose some mobility over time if they're not continually stretching into that, but they're probably going to stay a little on that hypermobile side most of their life.
Okay. Can either one of you put your foot behind your head?
Once I can do it one time, and then I got to go to the hospital or something.
Yeah.
No, but my kids can.
Yeah, but
Yeah, my leg would break.
that was my other example of functional hypermobility. Would be a third trimester pregnant mother. They get hypermobile to get ready for birth, right? So that's not a hypermobility that needs to be corrected. It needs to be, handled if there's pain. So, yeah.
Right. And what we do is we just strengthen as much as we possibly can. I mean, we can't change their hypermobility. That's hormone driven.
Mhm.
Um, but we strengthen or brace or work on stability to help them function during pregnancy.
Mhm.
Okay. So it sounds like a lot of this, if not all of it, is going to build stability around the joint, build strength around the joint, that type of thing. So send them to me. We'll work on,
Yeah,
we'll work
that's a
on
great
some
point actually,
stability.
because once, so a lot of people, at least when I was working in orthopedics with children, um, a lot of times I would refer to personal trainers because one, um, it's sometimes the issue that is involved is single joint or it's just strengthening, right? And long story again, another podcast. We can't really justify. Oh, we're just working on strengthening for to insurance, right? I wish I could, but sometimes I can't justify that, and so I'm like, look, you need strengthening, but I can't get insurance to pay for it, so go to this personal trainer. They can help you with this kind of thing. So yes, this relationship you and I have that has been lasting for 15 years is still continuing. So
I'm
Yeah,
glad to know I'm
another
still
reason.
important.
Oh, another reason that we don't take insurance, because I can spend as long as I want strengthening, but when someone gets to the point where they understand what they're supposed to be doing, they have good control of those muscles, and it's truly just like go work out and strengthen your body, then I also refer to personal training, because it's not my skill set, and frankly, I don't want to do it.
Yeah, that's why you come to me.
Exactly, exactly.
All right. So I'm going to mention this probably every episode, but I just want to put this out there again that, guys, we're not trying to diagnose you. And I think that's really important to understand with today's topic, that obviously you see there are several different forms of hypermobility. If you suspect that you are hypermobile, you have an issue with this, you need to see a professional, get diagnosed with what's actually going on so you can have the proper correction for it. So that about covers it for today. Did you guys have anything else to add?
no, stabilize.
All good. Stabilize everything. So don't forget, guys, like, subscribe, share. Also, we need some more topics. So I need you guys to shoot us some comments, messages, text, whatever, with some topics to cover that relate to your actual life. Thanks for joining today's episode of Symmetrically Fit. Until next time, stay mobile, but not too mobile.